Okay, good morning, everybody. It's a pleasure for me to open this second day of the Lugano Summer School 2020, starting with the plenary today. And it's a big pleasure to welcome Professor Joanne Atkinson from Sydney. So Joanne and all the colleagues from Sydney, good afternoon, because you are 8 hours ahead of us. So your workday will be done after that. Plenary hour will start. So Professor Atkinson is the head of systems, modeling, simulation, and data science, and the co-director of the Mental Wealth Initiative at the Brain and Mind Center at the University of Sydney in Australia. She and her disciplinary teams are developing interactive decision support tools used by government departments and service planners to forecast the impact of decision options before implemented in the real world. And we are all looking forward to your talk, Joanne, because I think for many of us, it's not so easy as you say in the title. So we are looking forward and to learn a lot from your side. Please, the floor is yours. Thank you.
Thank you very much. I'll just see if I can share my screen. Can I share the screen? Oh. Here we go. Okay, can you see my screen?
Yes.
Wonderful. Okay, so I'd like to start by acknowledging the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples. I'd also like to thank the Swiss School of Public Health for the opportunity, generous opportunity to present today on Australian experiences of applying systems modelling to support strategic policy and planning decisions. So in trying to address complex health and social problems, decision makers around the world face a number of challenges. These challenges can include the complexity of many population health and service delivery problems. And this complexity makes it difficult to understand where best to intervene and how impacts of initiatives to strengthen health and social systems might play out over time. There are often a broad range of options for intervening to improve population health in health systems, many supported by evidence, but there's still uncertainty about the likely effects of different combinations of interventions. Which combinations will be more effective than others? There's uncertainty about how they will perform in different contexts due to variations in community resources and community cohesion that can support implementation. There's variation in the availability of skilled workforce. There's variability in the acceptability of interventions and therefore uptake of them. There's uncertainty about how successful pilot programs and initiatives will scale up and what knock-on effects they might have on other parts of the system or potentially generate some adverse unintended consequences. And even within countries, there's regional variation in population characteristics, in risk profiles, in service needs, and in service capacity to meet those needs. And therefore, different combinations of interventions might work best in different regions. So needs also could change over time. There's demographic shifts or major changes in socioeconomic circumstances or the policy environment or sudden major national and global shocks as we're currently experiencing. And these could all rapidly change risk profiles and care needs and service demands, which can be challenging to address in a timely and efficient and effective way. A needs assessment only gives us a snapshot of population health needs at a given point in time. So by the time resources are mobilised to meet current needs, those needs have already changed. And of course, there are different perspectives on the problem and competing expert and stakeholder views on what should be done, which can prevent consensus on the best course of action. And of course, we know that sometimes even the best intentions can lead to unintended consequences that are hard to anticipate when we're focused on only a particular component of the problem rather than seeing the full picture. So traditional analytic tools can fall short of being able to adequately analyse complex systems, manage uncertainty and determine the best strategic actions. So what can systems modelling and simulation offer to help address these challenges of policy and strategic planning? Systems modelling is also known as computer simulation or dynamic simulation modelling, and it provides us with a way of mapping and quantifying complex problems, bringing together best available evidence, data, knowledge to produce an interactive decision support tool that creates that safe virtual environment for testing and forecasting the effect of alternative policy or planning scenarios before we implement them in the real world, potentially saving time, resources and lives. So when we first engaged with health policymakers, one of the first barriers we faced was their dissatisfaction with modelling in general. They told us that models are black boxes, assumptions are often hidden, and there was no real understanding of how systems modelling was different to other traditional statistical economic modelling that, in their mind, failed to capture the real complexity of issues they face, and nor did they trust backroom modellers in their understanding of the real issues and challenges on the ground. And so the results sometimes in their eyes lacked credibility. They also told us that even if they trusted model outputs, their stakeholders would not, and they'd likely have significant policy resistance if decisions were based on modelling results. So for the last 5 years, we've really been committed to taking this sort of modelling out of back rooms and into meeting rooms and exposing the work to open, transparent and participatory processes. So we bring together representatives from academia, from policy, program planning, clinical practice, economics, the private NGO sectors, local government, emergency services and consumer representatives to co-develop these models. Having stakeholders get under the hood to critique the structure and parameters and assumptions that underpin these models helps ensure that the final tool is credible, valid, robust, and grounded in the local context. It also generates greater confidence in the model outputs and insights. And the approach we've found has really delivered significant benefits in facilitating communication between the different players in the system. And can help advance contentious debates. And it also empowers communities by helping them understand system behaviour and why some strategies are likely to have impact while others won't. And it facilitates consensus building for collaborative action for implementation. So model development moves through phases of collaborative mapping to conceptualisation, to the development of the computational model, drawing on best evidence and data, and underpinned by iterative verification with the stakeholders. Stakeholder participation in model building is by no means a token gesture. It's absolutely invaluable. The knowledge shared by stakeholders has been vital to understanding system barriers and behaviours, perverse incentives, bottlenecks and hidden pathways that can't be found in any academic paper or administrative data set. So systems modelling is different to traditional statistical approaches such as regression modelling that articulates statistical associations between risk factors and outcomes. Systems modelling is causal modelling. It articulates a complex causal mechanism underpinning the interrelationship between risk factors and dynamic drivers of a particular health and social outcome. As an example, this is a high-level summary of one of our mental health system dynamics models where we've drawn on decades of research and to articulate the unidirectional and bidirectional relationships between the risk factors of suicide. And the model has an age-stratified population component capturing changes over time in the size and composition of the population resulting from births, migration, aging and mortality. It has a section that captures the changes in prevalence of psychological distress, which influences the rates of suicidal behaviour and is influenced by changes in the social determinants and also people's interactions with the mental health service system. And it captures the interaction between the social determinants themselves, namely early life exposures, substance abuse, domestic violence, homelessness and unemployment, and their influence on psychological distress. So as an example, when there's an economic crisis, as there currently is, and unemployment rises rapidly, not only does it have a direct effect on the rates of high to very high psychological distress in the population, which then has knock-on effects on the rates of substance misuse and rates of adverse life exposures, but it also affects the rates of domestic violence and rates of homelessness, both of which further exacerbate levels of psychological distress and so on. So these are the feedback loops that drive the vicious cycles and the virtuous cycles we know exist in the real world. And through systems modelling, we can see what impacts might occur across the system and on key outcomes if we intervene on one or multiple parts, components of that system. And I'll pick up this example later as we look at the mental health impacts of COVID-19 and economic recession. So a range of data sources contribute to informing the structure and parameterization of models, and the data needs really depend on the scope and stratification of a particular model, which is determined by policy and planning priorities or what the key questions the model aims to address. Data to parameterize or validate models is never perfect. There's often gaps, and we triangulate across a range of sources, including administrative data sets from health, social and economic sectors, from longitudinal studies, from available published research evidence, and from expert and local knowledge. So because these models represent a causal hypothesis of the structure and behaviour of a given system, this hypothesis really needs to be tested and validated. And this is done in a number of ways. We test whether the model can reproduce historic data across a range of indicators. And in this example, the blue line represents the real world time series data from 2011 to 2017. And the red lines are the outputs of the model. So because the model broadly reproduces past rates of psychological distress, psychiatric hospitalizations, ED presentations, self-harm hospitalizations and suicide deaths, we can have some confidence in the validity of the underlying causal mechanism and in forecasts of the relative impacts of intervention scenarios. In addition, we ensure face validity of the model's structure and performance among the diverse system actors through the participatory processes. And as an ongoing step, these models really should be embedded in ongoing monitoring and evaluation cycles. So this really allows continuous feedback between the real world and modeled systems to facilitate their further refinement to improve the forecast capability over time. We then integrate interventions prioritised by the stakeholder group or commissioning agency by detailing the mechanism by which interventions have their effect, trying to properly account for intervention timing and duration, target populations, reach, adoption, time to full effect of the intervention, any waning effects, and of course the cost of the intervention, both the establishment and maintenance costs. We then specify where in the core structure of the model the intervention acts. So each of these red dots you can see are interventions. So for example, we ask, does the intervention act to increase the rate at which people are seeking assessment or treatment? Does it act to improve treatment adherence? Does it act to reduce the rate at which people disengage from service systems? Programs and initiatives can act in one or multiple parts of the model. And it's not until we run the model that we see how it plays out across the complex system and over time, and what impact it has on a range of key outcomes, either on its own or in combination with other interventions. Just see if I can play this video. Okay, so once the core structure of the model is built and the interventions integrated, we then overlay an interactive interface that allows end users to ask a series of what-if questions. It allows them to turn interventions on and off, scale them up and down, stagger their implementation, and test the impacts of different combinations of interventions against a baseline of business as usual. The model can then be used to help weigh up the quantitative trade-offs of selecting one suite of interventions over another and determining the best targeting, timing, scale, frequency and intensity of interventions required. It also allows end users to see the impacts of intervention scenarios on a range of outcomes by scrolling through the different graphs. The results can also be viewed numerically or in any way that's meaningful to stakeholders to facilitate policy dialogues. So the costs associated with the outcomes with service utilisation and interventions can be integrated into these models as well and assigned to different payers such as the federal government, state government or consumer out-of-pocket costs. So when the interventions are switched on, the annual and cumulative costs occurred in the health system are more broadly and dynamically calculated. The flexibility of these models and the different interfaces facilitates a pragmatic approach to economic analysis that might be of interest to different funders, such as a public finance perspective showing return on investment, a health sector perspective reporting on cost effectiveness or cost utility of alternative combinations of interventions, and a societal perspective allowing a cost benefit analysis. So providing multiple economic perspectives helps to identify opportunities for multi-sector approaches to develop, fund and implement the most effective combination of strategies and mitigate against this short-term and siloed approaches to responding to complex problems. In the interests of transparency, we put as much information as possible in the interface. So for each intervention, we have this control panel that makes explicit the assumptions and the default parameter estimates and allows end users to change those assumptions and explore the implications of alternative assumptions. There's also an information button that provides details about how the intervention was defined, how it acts in the model, and the evidence and data sources used to derive the default parameter estimates. So in Australia, this work's been undertaken in partnership with national and state policy agencies and regional program planners across a range of areas, including alcohol-related harms, tobacco control, childhood overweight and obesity, chronic disease prevention, as well as child protection, homelessness, and we have a growing program of work in mental health and suicide prevention. And these applications of systems modelling have revealed a range of unique insights important for policy and planning. One of which is that more is not necessarily better. So this is a suicide prevention model developed by Professor Mark Heffernan and developed in partnership with Western Sydney Primary Health Network and their stakeholders. And the best overall combination of interventions that delivered the greatest impact were suicide, post-suicide attempt, assertive aftercare, plus community support programs, plus new interventions to re-engage those lost to services, as well as increases in mental health services capacity and workforce and training. Implementing all other interventions being considered by the region on top of that best combination was forecast to deliver little additional benefit. So knowing this helps really to focus our limited financial and human resources to achieve the greatest impact rather than spreading resources too thinly. Our models have demonstrated that sometimes interventions can have unintended consequences. So this is a mental health services planning model that was developed by Dr. Adam Skinner in partnership with a rural primary health network in Western New South Wales that showed that sometimes even evidence-based interventions can deliver unexpected results. So 2 priority interventions being considered by the region were GP training to better identify those at risk of suicide and refer them for treatment, as well as improving mental health literacy across the population to increase treatment seeking. However, GP training was forecast to deliver disappointing impacts on suicide behaviour, and mental health education on top of that made things even worse. So when we looked at the model in detail to try and understand why, we found that the combination of these 2 interventions were driving increased demand to an already stretched local mental health service system. Increasing service disengagement rates due to increasing waiting times and dissatisfaction with the quality of care. And this increases the duration of people in states of high psychological distress. It increases presentations to emergency department and increases suicidal thoughts and behaviours as people lose hope that the system can help them, or worse, experience further trauma from receiving inadequate care from an already stretched system. In this same model, if we then increase service capacity, on its own, it seemed to have pretty disappointing effects. And then, of course, we know that, that the combination of GP training and mental health education made things even worse. But if we increase service capacity ahead of implementing interventions that drive people to mental health services, such as the GP training and awareness raising campaigns, together they actually have a synergistic effect in reducing self-harm hospitalizations and suicide deaths. These models can also help us manage expectations. So in 2016, a state health department asked us to develop a systems model to explore how best to achieve a target set by the New South Wales Premier to reduce childhood overweight and obesity by 5% by 2025. And the model, this model again was developed by Professor Mark Heffernan, and it demonstrated that even if the health department scaled up their existing programs and services to achieve an ambitious 85% reach and 80% adoption, this would still only achieve a 3.1% reduction in childhood overweight and obesity. And that actually cross-sectoral investments in built environment and infrastructure and sport and active transport were needed. But these too were unlikely to achieve the target until sometime in 2026. So additional strategies would be required to achieve the target in the time frame. The model also showed that the earliest that even a small 1% reduction in the prevalence of childhood overweight and obesity wouldn't be seen until about 2020 or 2021, which really helped manage expectations around reporting of progress towards a target. So these models can help set more realistic targets for impact and can help understand what sectors need to really work together to achieve those targets. A national model of osteoporosis and related fracture burden developed by Dr. Danielle Curie demonstrated the importance of the time horizon. And this graph shows the cumulative number of fractures averted for each intervention tested in the model. A 10-year time horizon suggests that the top 2 performing interventions were the provision of exercise vouchers for falls prevention programs and vitamin D in residential aged care facilities. But over a 20-year time horizon, the best bets look a little bit different because some interventions have amplifying effects over time. And this has important implications for evaluation. For example, if a national risk identification program, which is essentially just screening and treatment, which is the blue line there, was implemented in 2020 and evaluated 3 to 4 years later, it would show little impact and possibly be subject to disinvestment before it had a chance to deliver its full effects. These models can also help us explore the impact of taking our foot off the pedal. So this example is from the model of smoking prevalence, developed again by Dr. Adam Skinner for the Queensland State Health Department and their stakeholders, who were concerned that successes in reducing smoking prevalence was leading to complacency with regards to the ongoing need for anti-smoking mass media campaigns. So the modelling provided the ability to demonstrate quantitatively the likely impact that disinvesting in these campaigns would have on smoking prevalence, providing a compelling argument for why tobacco control should not be considered finished business. And most recently, we've been rapidly deploying our mental health policy models developed at the Brain and Mind Centre to run scenarios that mimic the impacts of the COVID-19 pandemic in terms of its effect on employment and social connectedness. So in a prototypic national mental health model in work led by Dr. Skinner, we used Reserve Bank of Australia projections of peak unemployment and duration of the economic downturn, as well as an assumption of a 10% reduction in community connectedness resulting from social isolation from the lockdowns, where people were working from home, not participating in sports, reduced participation in social gatherings that would persist intermittently for a period of about 12 months. And so here are the model outputs, with the blue line representing what the trajectory would have been if the pandemic had not occurred, and the red line, the revised forecast under the best case scenario for unemployment, peak and duration, and reduced social connectedness. So you can see there's significant negative mental health impacts projected over the next 5 years and beyond across Australia, with the prevalence of psychological distress to peak at around 40% by December 2021, and among youth by 48% by September 2021. The proportion of youth not in employment, education or training is projected to rise to a peak of 26% in major cities and 31% in regional areas by September this year. Mental health related ED presentations will increase by 11%. Self-harm hospitalisations, which are indicative of suicide attempts, will increase by 12%, and suicide deaths by 14% over the period 2020 to 2025. The recent more pessimistic outlook in Australia, with recurrent outbreaks and intermittent hard lockdowns in regions, is really suggesting that these estimates are likely to be very conservative, and we are working to update the model as new information comes to hand to revise the assumptions. So these graphs show the projected impacts of the prevalence of psychological distress, ED presentations and suicide of a range of mitigation strategies, including employment programs to keep people in work and mental health system strengthening initiatives. And this is the real value of tools such as this, to really not only forecast the scale of the mental health crisis to come, but more importantly to really test a range of mitigation strategies to see what's going to flatten this curve as well. So the key insights are that unemployment programs, which you can see is the orange line here, are the single most effective strategy for mitigating the adverse mental health impacts of the COVID-19 crisis. However, we found that ceasing these programs too early in the trajectory of economic recovery undermines their impact, with at least 2 years of support required. These programs have more immediate effects in reducing the peak of the impacts, but they do plateau over time. So we also need large additional investments in health system capacity, technology-enabled coordinated care, and assertive post-suicide attempt assertive aftercare, which is the green line you can see. in order to flatten this curve. And substantial increases in health system capacity have an amplifying effect over time, but they don't reduce the peak adverse effects, and impacts are unlikely to be seen until 2022. So we really need to combine the two to have maximum impact, and that's the purple line you can see there, in order to reduce the peak and duration of the mental health crisis. So to better understand why, the bathtub provides a good analogy. So the tub represents the proportion of the population experiencing psychological distress, and the taps contributing to psychological distress during the pandemic and economic downturn include unemployment, anxiety about potential unemployment, including a partner or family member becoming unemployed, and social dislocation. So effective mental health services act to drain the bathtub. So if the inflows are significantly greater than the outflows, and the levels of psychological distress and the adverse effects from that in the community rises. And employment programs act to turn down the significant inflows, and expanding specialist community-based services widens the drain pipe and acts to shorten the time it would take for the levels of psychological distress across the communities to go down to pre-COVID levels and below. But this still takes time to see a significant reduction in the level of the tub. So this COVID mental health modelling highlights the importance of a coordinated whole of government response, not just a mental health system response, to deliver the most effective strategies required to safeguard a country's most valuable resource, its people. So these models have been used to support recommendations in ministerial briefs. They've been used to inform investment decisions by health and government departments and local primary care decisions. They've been used to facilitate engagement of stakeholders in strategy dialogues and consensus building for collaborative action. They've been used to help set more realistic targets for impact and manage expectations regarding progress towards those targets. They've been used as advocacy tools to help add extra strength to business cases for more stable long-term funding in health systems strengthening. And they've been used to demonstrate the consequences of disinvesting in programs. But importantly, they've also been used to help identify priorities for new data collection. So, you know, we've found in our models that there are many data gaps, but some data gaps are more important than others in terms of our confidence in model output. So models really help ask, you know, what's the next most important piece of data we need to collect in order to make better public health decisions. So the mental health challenges of the current pandemic and global recession will be significant, particularly for young people and particularly for those in low to middle income countries. While this modelling has been long used in infectious disease control and elimination and has evolved over half a century, comparatively it's rarely used to inform broader health and social problems in low to middle income countries. And perhaps one of the reasons is the perception that there isn't sufficient data to support it, or there may be other reasons. But I would argue that this perspective really deprives low to middle income countries of the very tools needed to effectively address complex and persistent problems. These models can be built based on a combination of theory and data, as you know, early COVID modelling showed us. And as more is learnt and understood and data systems are strengthened to inform the modelling, they increasingly become more robust. So it's important to invest early in building this decision support infrastructure. So to this end, Foundation Botnar has generously funded CSART and its international partners, including Swiss TPH, University of Lugano, University of Saskatchewan in Canada, Universities of Sydney and Western Sydney, and PUJ in Colombia, to take our systems modelling infrastructure from Australia and work collaboratively with young people and academic partners in Bogota, Colombia. So this work, we hope, will demonstrate the feasibility of engaging in similar processes of participatory development of these advanced decision support tools and embed them in in ongoing monitoring and evaluation to strengthen mental health systems over the longer term. So computer simulation has a long history of use in other sectors to support strategic investment decisions, to achieve advanced technological exploits, to support workforce training, and to improve efficiency and public safety. Countless lives are saved globally by our ability to model, simulate, and forecast the path, severity, and duration of significant weather events before they hit, and to simulate and test alternative evacuation and disaster response scenarios before they occur. While systems modelling has not been routinely used to inform health and social policy and planning, momentum is building. The value of systems modelling has been brought into sharp focus over the last 6 months and is really entering into the consciousness of the general public in a way that it never has before. And it has certainly been used to inform the successful national responses in Australia to the threat of COVID-19. And in Australia, we even watched as our Prime Minister addressed the nation, supported by modelling results to justify the measures being taken to successfully flatten the curve and save lives. Oh. So imagine what we could achieve if the health and social sectors were more broadly and routinely used computer simulation as part of the toolkit, as other sectors have successfully done. And imagine how powerful these tools could be if coupled with strong data infrastructure that would allow regular update of models with new data coming in, improving their predictive capability over time. With decades of research to draw on, with advances in technology and digital data capture, with increases in data literacy, with significant donor investments being made, and with the tragedies unfolding around the world, there's never been a more important time to bring advanced decision support tools to bear in supporting strategic investments that make best use of limited resources, help nations rebuild, and put in place the infrastructure needed to deliver more effective outcomes for the communities we serve long into the future. Thank you.
Thank you so much, Jo. There's over 100 people watching you on Zoom and YouTube right now, and I'm sure that they are also clapping. I'm sorry you can't hear that. That's one of the downsides to this technology. Wow, just incredibly impressive, the work that you all do. One of the questions that I had for you, you started to answer, and that was about when a community perceives themselves to not have enough data. And I'm sure that, you mentioned the example in Bogota. Do you have other examples of where you've been faced with just that very first confrontation of we would love to do that, but we don't have enough data? Where do you take that situation? What can you recommend?
So as I was kind of probably starting, as you said, to go down, I think that models can really span, or systems models can really span that continuum from almost purely theoretical to entirely data driven, and even towards the theoretical end, they can deliver important insights for strategic decision making. And in the early phase of the pandemic, very little was known about COVID-19, but they were still enormously important in guiding our responses. And of equal value is their role in understanding what is the most important data we need to collect, and to refine the models and reduce that uncertainty over time and make better and stronger decisions. So yeah, I think perhaps there is some more, Ante or Mark, you would like to add to that from your experience.
Ante or Mark, if you'd like to speak.
Or no, maybe they've gone to sleep.
Here? Hear us? No,
Yes, I can hear you.
I think we can build the models that are in capturing causal mechanisms even without data, and that help us to pinpoint what data we need to collect even before we kind of embark to that data collection. And because often we collect data that we don't need really, or that don't have such a crucial role in the modeling, and collecting data can be very expensive. So that's maybe the only kind of aspect that I could add.
So we have, thank you. We have another question coming from Mike, who asks, what can be the best strategy to let governments and policymakers in low and middle income countries be responsible to the results of modeling to respond to public health problems? It seems that even for the current studies, it's very difficult to convince them. Can we make awesome models for communities so that they understand and take actions?
That's an excellent question. I would completely agree with the idea of using modelling as a form of community empowerment. It's a really powerful exercise in, you know, we have, certainly in mental health, you know, there's the voices of people with lived experience and their frustrations of engaging with mental health systems that are not providing adequate care, and that's most likely a common experience across a range of areas, not just in mental health. And there, you know, there is a lot of advocacy that they do in order to try and get their voice heard. But what we're finding is, if we can, by engaging in these participatory processes, collectively, you know, having these models represent our best understanding of the system and the way it works, and then providing them with outputs of the model that they can then use to lobby in a far stronger way governments to you know, mobilize resources to help address the challenges. It's a more powerful message than advocacy alone.
So I can imagine, but I also know that the effects of this kind of modeling also might step on the toes of some. So if you have your favorite intervention, or you've got a department in charge of this type of intervention and they love it and they believe in it, but your model shows that it is not effective or possibly could actually do more harm, do you have advice for us on how to handle such situations?
That's yes, that is a common experience with our work, and certainly it's you know, it's tricky waters to navigate, but through the model building process, we really try to work on building trust and transparency, and as we're you know, sometimes people's favorite things that they've been long advocating for don't show the impacts that they had anticipated, or sometimes it's you know, on their own they don't have the impacts they anticipated, but in combination or under different conditions they do, and so understanding that is, you know, is helpful to people. But it also helps them, you know, it's a systems learning process, that if it's not having impact, understanding why it's not having impact, being able to change the little sliders to change the assumptions and say, oh, well, maybe it's because we've assumed X and that's just simply not true. Let's change our assumption. Does it work even in that scenario? And still not. And, you know, so it really, it is a process of learning that can be quite challenging when it challenges our worldview. But I think we, through the participatory process, really aim to build trust and facilitate that learning.
Okay,
Thank you.
if I could just jump in here.
Yes, please, Mark.
Like Jess, I think when the model doesn't give you the answer you expect, sort of chasing that down often gives you the most understanding, because you're challenging. You've got to sort of defend your thesis, and I mean sometimes the model might be wrong, but generally it's person's understanding what's actually happening. Now, I did a lot of work for the military for for many years on some of our fighter planes, and the given wisdom was that a certain piece of equipment got changed out every 4 years. And so when they were looking at doing planned withdrawal, they looked at how many aircraft they had, how long they wanted to service them for, divided that by 4 and came up with the number of parts they needed to buy. We came up with a number that was about 30% more than that. And they said, why, how can this be? And then the guy from the workshop floor came up and said, well, the aircraft come into the hangar once every 3 years, and we take it down so far that we can see that part, so we change it out. So this was something that, what my friend Tim Haslett says, is local rules that people use to get by, that don't make it all the way to the top of the people that make the decisions. So sometimes when you explain that, they say, oh yeah, I can understand that. And often it's not quite that easy, but there's usually a good explanation for it.
Thank you, Mark. Jane?
Yes, so now we have also an anonymous question, and it's the following. How do you overcome resistance from governments over using such models? This has been a problem for the Philippines and COVID-19 response. Yes, exactly, Philippines, I'm sorry. COVID response, whether they initially felt being challenged by researchers who are conducting modeling studies on COVID. Can you hear me?
I think I caught most of that question, and absolutely it can be a challenge. And even though our Australian government embraced the COVID transmission modelling from well-respected institutes, from the Doherty Institute and Burnett Institute, it was curious to experience some resistance with the same type of modelling, but in mental health. So there's almost like a kind of a culture of using models and engaging in models that we have to build, and we have to build trusting relationships with decision makers, so that first that they kind of consume the outputs of the model, then because it actually solves real questions that they don't have the answers to. I think we're some way away outside of infectious disease modelling to get governments to embrace modelling as in a more routine way. We're finding more success with regional areas, and so we have a situation where we have some decentralisation of funding and decision making about how to invest to strengthen mental health systems. But what didn't come with that devolution of funding and responsibility were the right decision support tools to help. So when we kind of went to some of these regions and we said, we understand your challenges with making decisions, and here is something that can help, and this is why, we haven't had any problems getting them to embrace this approach, because it solves a real practical problem. We're having a different experience at the higher national level. So I'm not sure that really answers your questions. I think it's going to be a slow habituation to this sort of works until it becomes a little bit less foreign to people.
Okay, I would say that in some cases you're just not going to do it. If you look at President Trump and the US, for example, they're just ignoring it. So you're not going to convince anyone there. But perhaps you could get to some of the state governors and things like that. But sometimes I've got to admit, you're just bashing your head against a wall, and you can say, well, it's obvious in hindsight this is what happened, and maybe it'll help the next generation.
Very nice. It's also very smart to know when to stop bashing that head against the wall. Ante, did you want to add something to that? Otherwise, we've got some more questions in the Q&A.
Yeah. Okay. I actually wanted to add that sometimes this resistance is also from health. from health professionals, not just government. That's where we actually face really huge obstacles, because for some reason, there are parts of the health professionals that are having huge issues with modeling, without actually knowing much about modeling, but rejecting it for some reason.
Yeah, that's absolutely the case. Our fellow researchers that are not used to using these sorts of modelling methods find it, well, I'm not quite sure why, but they're very concrete in thinking about, you know, things in a very reductionist way, and kind of dragging them, you know, to some extent you can drag them into systems thinking, but then engaging in the system science modelling techniques is quite a big leap for researchers to make. So I think, you know, it needs to be part of the curriculum in our public health courses to really start changing the thinking or opening up, you know, but this is not a replacement of traditional analytic methods. It is just a part of the toolkit that offers value. And so the training in this area needs to really occur from the outset in training in public health research and practice.
Brilliant. So another innovation of this edition of the summer schools, we have our first ever course, a 3-day course in systems analytics that you all are leading. And we have quite a number of participants. So thank you very much for offering that and building capacity in this area. We have two other questions. I'm going to ask them at the same time so you can take them as you wish. The first one is that if a government, regional authorities, maybe it's a hospital system, wants to do this and they see the value in modeling, but they don't have the expertise in-house, or they don't feel like they see a system like yours and they see your slides and they say, wow, that is just really cumbersome, looks expensive. You know, where do they start? That's question one. And then another question from Lena, who is a nurse here in Switzerland and is is one of the attendees, excuse me. She's asking, COVID-19 is affecting mental health, not only of the population, but also of frontline workers, medical doctors, nurses. Strengthening the overall health system in order to respond to the demand and to provide the needed support for health workers is therefore crucial. How to choose the best intervention to improve the mental health and stigma of health workers, and therefore strengthening the health system on policy as well as the community level.
Yeah.
Turn it over to you.
So to the second question, I completely agree, and absolutely these models really, like you can probably didn't mention, but you can stratify these models by different subgroups in the population so that you can look at the differential impact of some of the strategies you're considering on the total population or different subgroups. And we haven't modeled specifically the healthcare worker mental health issue, but I think that's it's a really important issue to raise. So thank you. I think there's some further development that needs to occur in that direction. The first question was about if you know, if people were interested, how do they engage in this sort of work? It looks complicated and expensive. So I think, you know, there are communities of people with their expertise around the world, and certainly Mark is well connected with the System Dynamics Society in particular, that have chapters all over the world. And I think we could do better in you know, connecting people up with potential users and people with the expertise, but we do need to build capacity, and CSART has come into existence for that very reason, that we wanted to kind of join up centres of excellence around the world, developing these sorts of or with these expertise and developing these sorts of models for health and social policy, to really broaden their application and help people and share tools and technologies internationally, so people aren't aren't starting from scratch, that we can build on the work that's come before, and we can really reduce the cost of these sorts of models by being able to leverage something that's already been done in Australia or elsewhere. Mark, is there anything you would add further to that?
I think for people who want to start, the easiest way is to get in touch with the System Dynamics Society and ask them if there's someone they could recommend, either through the Health Policy Special Interest Group. That's a sort of, if you like, an advert-free way to start. For this kind of modelling, there's basically 3 lots of software out there. There's Stella, who we're using and I represent, Vensim, and AnyLogic. Vensim has a free sort of PLE, a light version that you can use. Stella's a bit more expensive, but if you're a student or an academic, you get it quite cheaply. And AnyLogic has some not so cheap alternatives, but most of these companies have online YouTube videos on how to do stuff. Also, Kim Warren has some stuff. So I'd say search YouTube as a start to see what's around. Or, I mean, there's some pretty old stuff around too on the sort of library of the System Dynamics Society, like sort of Jay Forrester's memos and things like that. So there's a bunch of stuff that goes back about 50 years on how to do this stuff. It's just been a lot easier in the last 5 years, thanks to Java and really cheap, fast computers.
Also, there's I really focused my examples on some of the higher level policy models that we've developed using system dynamics modeling, but of course there's also agent-based modeling and discrete event simulation. So agent-based modeling really focuses on modeling a population of individuals where you can capture all the heterogeneity and the issues. And then discrete event simulation is kind of more process-centric modeling. If you're modeling patient flows through emergency or trauma center or a particular service, that you can go and look at resource optimization of resources and improving efficiency. So there's multiple modeling techniques. It's important to mention that also the CSART's chief scientist, Professor Nate Osgood from the University of Saskatchewan, is a world leader in agent-based modeling and quite broadly in systems modeling, but he also has built up over 15 years a lab of very talented computer scientists and other students that are kind of potential, the future resource. And he also has a series of online lectures on building agent-based models and that sort of thing. Ante, was there anything further you would add in terms of agent-based modeling and discrete event simulation?
No, probably just maybe mention some resources for learning, such as NetLogo, which is there already for like almost 20 years. So there is quite a bit of resources for learning. And obviously, we are planning in the future through CSART to make available a library of different models that can be reusable, and also some pre-built template for modeling that would make it easier for beginners to deploy.
Fantastic. Well, another person in the chat has that question. And so I think you just answered that in terms of giving some resources. So CSART would be a good place for them to start. And then a good search on YouTube. Also a search for Systems Dynamics Society, Stella Software. Yeah, okay, super.
Yeah, but feel free to contact us if you've got any other specific questions. We can connect you with our colleagues around the world if you let us know a little bit more about the particular problem you're looking to model, or we might know someone that will be able to help you in a particular country.
Fantastic, thank you for that. And so we are at 10 o'clock Swiss time. And I want to thank you so much for this fantastic plenary lecture. I think you've opened the eyes and minds of a lot of people, and we are excited. Data-driven decisions, oh, what a place we should be. So thank you very much. Thank you for joining us from Sydney, Australia this morning and this evening for you. Thanks to everybody who's joined us online. As I said, we had about 110 people watching total here on Zoom and then through YouTube. The video will be available on YouTube. And so you can go to the Swiss School of Public Health playlist on YouTube and you can see this. If you have any other questions, of course, we're here for you. Joe, thank you very much. Mark, Ante, best wishes. And you've got to go get to a course now on systems analytics.
We do. Thank you so much, Suzanne and the Swiss School of Public Health for hosting us.
With great pleasure. Thanks.
Thank you.
Bye-bye.
Bye-bye, everybody.